Bismillah wa salatu wa salam ala Rasulillah. Assalamu alaikum wa rahmatullah. Good evening, everyone, and welcome to new episode of Saudi Society Bone Marrow Transplant webinar series. Tonight, we will have a distinguished talk about MDS, which is this night webinar is supported by Bristol Myers Squibb. And the agenda for tonight is going to be a discussion about low-risk MDS. My name is Badr Al-Ahmari. I am a consultant stem cell transplant and cellular therapy Department of Oncology, National Guard Health Affairs in Riyadh. As I mentioned, this talk is supported by Bristol Myers Squibb. Many thanks for their support. So as we know that myelodysplastic syndrome is genetically defined disease with characterized by extensive cytopenia resulted from bone marrow failure and effective erythropoiesis with a marked cytopenia, mainly anemia and thrombocytopenia. And we know that this is a disease of elderly with increased median age of presentation is around 70s, with carrying the poor 5-year survival in compared to other type of cancer. And of course, the 5 years overall survival depending on the risk stratification of myelodysplastic syndrome. So tonight we have a distinguished speaker, Prof. Tariq Abu Zaid. He's a professor of hematology, Faculty of Medicine, Al-Mansoura University in Egypt. He's also consultant of hematology and hematopoietic stem cell transplant and head of department at Al Muwassa Hospital in Dammam, Saudi Arabia. And he's going to talk about how I treat myelodysplastic syndrome, new therapeutic approach for low-risk MDS. Prof. Tariq.
Okay, Assalamu alaikum. First of all, many thanks our dear colleague, Dr. Badr Al-Ahmari, one of the eminent hematologists in the region. Okay, and it gives me the honor to present my talk today with my dear colleague and friend, Dr. Badr Al-Ahmari. And a special thanks goes also for Bristol Myers Squibb for give us this opportunity. I'm gonna share my screen right now. Okay. How I treat MDS and new therapeutic approach, as our colleague Dr. Badr previously mentioned, that low-risk MDS or MDS is a heterogeneous clonal hematostem cell neoplasm that occur predominantly in aging population. The main challenges we are facing in managing low-risk MDS are two: the chronic anemia and transfusion dependency. The overall survival varies with the degree of anemia. Best overall survival has been seen in patients having hemoglobin 10 gram or more. They have around a 5-year overall survival, whereas patient with severe anemia, as defined as less than 8 gram per deciliter, may have an overall survival of 2 or less years. Transfusion dependency is often one of the commonest indicator for severity of the disease, as anemia often treated with RBC transfusion. Around 50% of the patient may require regular transfusion within 2 years from diagnosis. Patients with MDS who are transfusion independent have 56% decrease in the risk of death compared to those who are transfusion dependent. And when we look to the probability of non-leukemic death and its relation with the anemia in both gender, patient in male patient with hemoglobin less than 9 gram per deciliter have poor overall survival and high probability for non-leukemic death compared to male patient having hemoglobin 11 gram or more. On the same, also in females with hemoglobin less than 8 gram per deciliter have higher probability of non-leukemic death compared to those having 12 gram or more, which means the severity of anemia is correlated with the probability of non-leukemic death. And when we look also for the transfusion dependence can be considered as independent indicator for disease severity. The effect of transfusion dependence is more noticeable in patients who are associated with severe transfusion requirement. According to a retrospective cohort study in more than 400 Italian patients with MDS between the year 1992 to 2004, patient who does not require transfusion per 4 weeks, passing to 4 unit 4 weeks. We looked at patient requiring 3 or more unit every month as transfusion requirement may have a 5-year survival less than patient with liver or lung cancers, which means it is more severe than two of the most aggressive malignancies. Therefore, the severity of anemia, the transfusion dependence is maybe associated with poor survival in low-risk MDS. And when we look for the relation between transfusion dependence and overall survival, when we look for overall survival, definitively overall survival in transfusion independent is much more better compared to transfusion dependent anemia. And non-leukemic death also in the transfusion dependent is high compared to transfusion independence, which means transfusion dependency and degree of anemia is correlated with poorer overall survival and high probability of non-leukemic death and AML transformation. What is the importance in low-risk MDS? According to the IPSS risk prognostic tooling, okay, we are classifying more than 77% of MDS patients as low-risk MDS. And the median overall survival is around 5 years. While with the addition of the molecular testing, MDS, according to the IBSM risk scoring, we have around 60% of MDS is a low risk. Therefore, we are talking about from 60 to 77% of MDS patients are considered as low risk, which are having chronic anemia and need further treatment. First line treatment for low risk MDS patient for a long time were consisting for erythropoietin stimulating agent if they are non-5q deletion. However, based on several clinical trials, okay, around 65% of the patient are either refractory relapsed to erythropoietin, and those who respond around less than 40%. In another trial, okay, 2/3 of patients who are low risk MDS are refractory relapsing to ESA, and the majority of them will receive RBC transfusion. If you look to the pie chart, okay, persistent responder to ESA only 32% of the patient who may respond and relapse later are around 30%, and around 39% are primary resistance. This is a treatment challenge for low risk MDS. What are the treatment goal and the risk we are managing? Living with MDS places a heavy burden on the patient daily life that will be discussed later, and early treatment initiation has definitive goals that will be mentioned later on. What are the burden of MDS on patient quality of life? 4 items: physical problem, role of functioning, emotional problem, and social functioning. Physical problem, around 40% of the patients with MDS have mobility issues, this leading to functional decrement in the virtual areas. Role of functioning, around 36% of the patient reporting moderate to severe problem in the usual activity, either work, housewife, or leisure activity. This leading to, if the patient is employment, increasing that day missed from work and sick leaves, leading to career opportunity decreasing. Emotional problem, 37% of the patient may have some degree of anxiety and depression. Social, 34% of the patient receiving transfusion felt their blood transfusion were burdening their family. All of these will affect the quality of life of the patient. When we initiate treatment, our treatment goal consisting of 4. First, to achieve RBC transfusion independence, obtain hematological improvement, improving quality of life, and try to improve overall survival and delay the AML transformation. As a result of that, we can improve the quality of life of the patient. How I treat low-risk MDS in the year 2025. According, if the patient is presenting only with anemia, as we know, we are looking for the 5q deletion. If the patient is having 5q deletion, we go for lenalidomide. If not responding, hypomethylating agent. If the patient is non-5q deleting, we're measuring the ringed sitroblast. Patient with MDS and associated with ringed sitroblast, luspatercept frontline treatment or imetisolate. If the patient not respond, we can add lenalidomide with or without EPO. If the patient not respond, hypomethylating agent from 3 or 5 days. If the patient is non-5q deletion with non-ringed sitroblast, measure the EPO level. If the patient having less than 200 microunit per milli, requiring 2 unit or less per month, okay, if yes, we can give erythropoietin stimulating agent. If no, we can start with luspatercept. If any of these patient lines does not respond, and the patient having hypoplastic marrow less than 60, we can give him immune suppressive treatment. If not, okay, if his risk associated low platelet count, very low absolute neutrophilic count, we can look for hypomethylating agent. If isolated anemia only, imizolate or lenalidomide with or without EPO. This was the treatment. According to the NCCN guidelines, okay, it's summarized. First of all, we are checking for the 5q deletion. If the patient is non-5q deletion, we can measure the SF3B1 mutation. If the patient is carrying this mutation, preferred line of treatment will be luspatercept. If the patient at any time not responding or relapse, we measure the EPO level. If he's having less than 500 microunit per milli, recommended is to start imizolate or erythropoietin stimulating agent, either ebutin alpha or darbebutin. If the patient is having high serum EPO level, preferred is imizolate if not used before, or luspatercept. Okay, therefore, if the patient is with symptomatic anemia, non-5q deletion without other cytogenetic abnormality and with ringed sitroblast, measure the serum EPO level. Patient with low EPO level, you can start with ebutin alpha or darbebutin or luspatercept. If the patient respond, continue. If no response, okay, to ESA, we can shift to luspatercept. Okay. What makes all of that so important? Because anemia is the hallmark of MDS that, along with various clinical sequelae, can result from ineffective erythropoiesis. When we look to the pathogenesis of MDS, it starts by the process of clonal expansion of bone marrow progenitor and dysregulated bone marrow microenvironment. As a result of that, there is increased production of dysplastic cells, increased level of apoptosis, leading to different types of cytopenia, leading at the end of ineffective erythropoiesis, resulting into anemia, leading to poor tissue oxygenation, iron overload from the recurrent blood transfusion, leading to cardiomyopathy and liver cirrhosis and fibrosis, abnormal bone marrow microenvironment, leading to stromal dysfunction and other cytopenias. What makes luspatercept, okay, an important agent in the management? Because when we look to the pathogenesis, it comes from the interaction of transcriptional growth factor beta superfamily ligand with its activin type 2 receptor. As a result of this interaction, subsequent phosphorylation of SMAD2/3 pathway, this activation leading to inhibition of the normal erythropoiesis, maturation arrest, increased apoptotic changes. As a result of that, there will be dysplastic features and cytopenias. But luspatercept, it binds with the transcriptional factor ligand, prevent its interaction with the activin receptor type 2. Subsequent phosphorylation of SMAD2/3 will be not started, leading to giving chance for normal erythropoiesis for maturation, differentiation, and normal RBCs production. The clinical benefit of this luspatercept offer a means to optimally treat chronic leukemia and low-risk MDS associated with complication. Luspatercept dependent durable expansion and maturation of erythroid precursor, leading to successful RBC transfusion independence. Luspatercept is the first treatment to show sustained increase in the hemoglobin level in either refractory or relapsing patient with low-risk MDS, reducing or eliminating the need of RBC transfusion with an established patient profile. Real-world evidence has shown that early initiation and optimal dose titration of luspatercept positively impact, resulting in maximum clinical benefit. And this comes from two important trials, the Medalist and the Command. The Medalist trial was conducted by comparing the use of luspatercept in patients with EPO-resistant or refractory cases. Primary endpoint was the presence of RBC transfusion interval more than or equivalent 8 weeks within the first 24 months. It showed that 37.9% of the patient received luspatercept become transfusion independence for more than 8 weeks compared to placebo. And secondary endpoint is hematological improvement has been shown into 52.9. But what further? As by Jan 2023, the median duration of treatment was around 50 weeks of luspatercept and 24 for placebo. And when we look for the data, as we mentioned before, during the first 24 weeks of initiation of the therapy, RBC's transfusion interval more than or equivalent 8 week were seen in almost 38% in luspatercept treated arm compared to 13% in the placebo. Furthermore, at the entire treatment period, with the prolongation of duration, we achieved almost 50% in the luspatercept treated arm having RBC's transfusion interval more than or equivalent 8 week compared to 15% in the placebo arm, and RBC's transfusion interval more than 16 week is seen in almost 31.4% of the patient compared to 7.9, which means with the prolongation of the duration, more and more patients respond, and the interval transfusion interval may be also increased. Safety issue. With the prolongation of the safety, okay, patient who progress to high-risk MDS has been seen in 5.9% of the cases treated by luspatercept compared to 3.9, whereas patient who progress to acute leukemia are 2.6% in the luspatercept treated arm compared to 3.9 in the placebo, which means there is no safety concern. Also, when we compare the fatigue with the dose escalation, treatment cycle, and hemoglobin level, we've seen that 60% of the patient receiving less than 1 milligram per kg experience fatigue. With dose escalation to 1.33%, it has been reduced to 39%. Only 14% who achieved the recommended dose 1.75 milligram per kg experienced no fatigue. Treatment cycle from cycle 4 on, okay, ongoing, the fatigue has been eliminated, which means during the first 4 cycles, the patient may still experience fatigue, but later on it will be reduced. According to the hemoglobin level, and I see it's typical patient who having hemoglobin less than 10, always 90% experience fatigue, whereas patient more than 10, 8% has experienced fatigue. At the end, after 6 or more years follow-up of patients with low-risk MDS received luspatercept treatment for more than 2 years, 41.3 and 64.6 of the patients who achieved transfusion interval more than or equivalent 8 week or 16 week respectively achieved uninterrupted transfusion interval more than a year. The rate of RBC's transfusion response increases with treatment time, as we shown with the prolongation of time. Okay, more and more patients respond. The long-term safety profile of luspatercept was favorable and consistent with previously shown in other study. No new progression to high-risk MDS or AML event have been reported in the last cut of data. Fatigue was transient as previously reported, and rate fatigue decrease within the levels. The other amazing trial is the COMMAND trial. The COMMAND trial is the first head-to-head trial by comparing luspatercept versus erythropoietin-stimulating agent in low-risk MDS. And when we look for the key eligibility of this is a global phase 3 non-open label randomized control trial by comparing luspatercept 1 milligram per kg subcut Q3 versus ibutine alpha 450 international per kg subcut weekly. They included patients with a very low, or intermediate risk MDS by WHO criteria, requiring RBC transfusion, endogenous EPO level less than 500 units, and ESA naive. And they are the patient demographic data. They included all the patient ages, sex, hemoglobin level, transfusion burden. They classified low transfusion burden who required less than 4 unit Q 8 week, and high transfusion burden who required more than 4 unit per 8 week. Serum EPO level, SF3B1 mutational status has been also included, whether mutated, unmutated, and the presence or absence of ringed sideroblast. When we look for the primary endpoint, in the intention to treat group, okay, we see that luspatercept treated patients, 60.4% of the patient respond versus 34.8 in the erythropoietin stimulating agent. But when we look for different patient subgroup, according to the transfusion burden, patient with low transfusion burden as mentioned before, requiring less than 4 units per 8 week. 66.9, which almost 67% in the luspatercept arm respond compared to 43% in the EPO arm. While patient with high transfusion burden, 48.4% in the luspatercept arm respond compared to 21% in the EPO arm. According to the baseline EPO level, less than or equivalent 200 unit per liter, okay, almost 66% in the luspatercept arm respond compared to 40% in the EPO arm. Patient having from 200 to less than 500 unit per liter, 37.8 compared to 10%. Also, in all patient subgroup, there is higher response rate in the luspatercept arm. Even in SF3B1 mutational state, in the mutated arm, 70% of the luspatercept patient has response compared to 32 in the EPO. In the non-mutated, 44.6. When we look for the presence or absence of ringed sideroblast, 65% of the patient with ringed sideroblast respond compared to 29%. In the absence of ringed sideroblast, 46 compared to 50. This is the only advantage in the absence of ringed sideroblast for EPO. As a result of that, okay, when we looked also at the hematological improvement and the RBC transfusion during the first 24 weeks, okay, patient with hematological improvement, okay, less than or more 8 weeks, okay, 75% almost in the luspatercept arm compared to 53%. When we look to the transfusion interval, more than or equivalent 12 week during the first 24 week, we are talking about almost 70% in the luspatercept arm compared to 48 in the EPO. And transfusion interval for more than 24 weeks has been seen in 47.8 compared to 39%, which means according to subgroup analysis of the patient, the primary endpoint showed greater response rate for luspatercept patient, regardless the baseline transfusion burden, serum EPO category, SF3B1 mutational status. Safety issues, okay. The median duration of treatment was longer in the luspatercept treated arm compared to erythropoietin arm, okay. 78% of luspatercept patient and 81% in the EPO of the patient requires one or more dose escalation. Similar proportion of the patient in both arms died during the trial. The rate to AML progression very low, 2.7 versus 3.3, and it's amazing results because there is no safety issues in this trial. And when we look to the fatigue and asthenia, reported rates of fatigue and asthenia during the weeks 1 to 24 decrease over time. Most fatigue and asthenia event in the luspatercept arm were grade 1 to 2 and were not considered clinically significant. Only one grade 3 fatigue event was reported and which did not lead to dose reduction or resulting into discontinuation from the drugs. And when we compare the value of placing luspatercept frontline treatment versus second-line treatment, here is a comparison between luspatercept frontline treatment than standard of care as a second line versus ESA frontline versus luspatercept second line. Sorry. When you look in the total months of life or survival, patients who receive luspatercept frontline treatment, okay, they lived for around 54.7 months compared to 49.3 months in the patient receiving ESA frontline and followed by luspatercept second line. Differences, we are talking about 5.3 months in advantage. Responding. In the patient received luspatercept as a frontline treatment, almost 60% are responder compared to 40% responder in the luspatercept treatment arm, which also in favoring to start luspatercept as a frontline because more prolongation of the overall survival and the response rate. Months of life with transfusion interval, patients receiving luspatercept frontline treatment have an average 22.6 months transfusion interval compared to 15.7 when they receive ESA frontline, then luspatercept second line, which means we have a prolongation in the transfusion interval around 6.8 months. And also in the response rate, 27.6 in the patient receiving luspatercept first line compared to only 4% when they receive it as a second line. Quality adjusted months of life, we are talking about, according to achieving quality of life, we are talking about 44.3 months compared to 38.3 months. Annual RBC's unit transfusion from 11.8 to compare to 13.4, which means also there is 1.5 reduction in the number of unit compared when we start luspatercept frontline versus ESA frontline followed by luspatercept as second line. Annual hospitalization, okay, 5.4 compared to 5.7. Annual ER visits, 4.8 compared to 5. All these models suggest that the earlier use of luspatercept in the treatment pathway lead to more benefit and survival and quality adjusted survival in the disease burden in terms of months of life, transfusion interval, and quality adjusted months of life. Another trial has been published in the last year by Aedis et al. Okay, by combining ESA and luspatercept in patients with low risk MTS after ESA failure. This phase 1 to 2 trial, okay, by combining luspatercept to erythropoietin stimulating agent in patients after failure to erythropoietin, okay, in this difficult to treat population, 1 to 2/3 of the patient achieved erythroid response with luspatercept and erythropoietin alpha. Based on this trial, the dosing schedule were 1.7 milligram per kg Q 3 weeks and ebutin alpha 16 unit per week was selected as the best available dose. Which means that even if the patient is receiving erythropoietin and failed, you can add luspatercept instead of replacing. Therefore, whether you start with luspatercept or you use the luspatercept after ESA failure, there is improvement in the patient response rate. And a patient model, we have this case. 77 years old female patient was referred to us in June 2021 with bicytopenia, normosec normochromic anemia, and thrombocytopenia. Her initial lab revealed in the form of normal TLC, hemoglobin 7.1 gram per deciliter, as mentioned, normosec normochromic, with a platelet count of 77,000, having a very high serum ferritin. Bone marrow has been done in June 2021. It revealed MDS low risk with ringed sideroblast associated with SF3B1 mutation, and IPSS risk scoring was 2. And the mutation has been done abroad. Patient comorbidity, non-insulin dependent diabetes, and hypertension. The patient gave history over the preceding 4 months of receiving over 6 units of backed RBCs with a transfusion interval around 3 weeks. We discussed with the family the treatment option. She had started darbutin alpha 300 mic subcut Q3 weeks in July 2021. The patient showed improvement in her hemoglobin and transfusion dependency in the form of having achieved hemoglobin rise, okay, without transfusion over the next 3 months. During the year of 2022, she had not transfused for almost 7 months. Excellent response to erythropoietin stimulating agent. In September 2022, okay, she was presented with a hemoglobin drop to 8.5 gram per deciliter and received 1 unit backed RBCs. And in January 2023, once again, she had another hemoglobin drop to 7.9 and received 2 units of backed RBCs. Despite the use of darbutin, she started to become transfusion dependent once again with 3 units of transfusion from January 23 with a transfusion interval of around 10 weeks. Reassessment has been done, including bone marrow and cytogenetic again and molecular assessment, and the patient were still low risk MDS with ringed sideroblast. And it's fitting that the patient who responding to ESA might eventually relapse at any time and become RBC transfusion dependent once again. Once again, we discussed with the family the option, and we changed it to luspatercept 7 mic Q3 in February 2023. She started to use luspatercept at a baseline hemoglobin 8.9 gram. In the subsequent visit, we noticed progressive improvement in her lab. Her hemoglobin reached 10.6 gram per deciliter in June, 12 weeks duration. The patient remained transfusion independent until January 24. She was admitted with severe upper respiratory tract infection, and she had a hemoglobin drop to 9 and received only 1 unit. At that time, she had a transfusion interval of almost around 11 months. Unfortunately, the patient has been admitted to the ICU last August with a gastroenteritis-induced AKI. Her hemoglobin at that time was around 13.1 gram per deciliter, but due to the hemoconcentration, due to the dehydration, she recovered rapidly and get discharged after a few days with a hemoglobin 12.6 gram. At that time, we start to increase the frequency of injection to Q4 weeks. Up to date, the patient never required transfusion since January 24, and she have a normalized hemoglobin, okay, fluctuating from 11 to 12 gram per deciliter, and we have achieved till now 17 months or more transfusion independence. This patient tolerate luspatercept well, apart from mild bone ache. Considering this, the age of the patient, and considering this amazing figure, 17 months transfusion interval, okay, for a 77 years old patient, it's an amazing. Lastly, what is coming for low risk MTS is the imetelstate. Okay, it is a first in class direct competitive inhibition of the telomerase activity that's specifically targeting the malignant clone with abnormally high telomerase activity and enabling recovery of the effective hematopoiesis. In the phase two trial of the iMerge study, patients with low risk MDS who have a heavily RBC transfusion dependence, either relapsed or refractory or ineligible, non-5q deletion, and naive to lenalidomide and hypomethylating agent continuous RBC transfusion. The data shows that specifically 8-week transfusion interval rate were around 42%, with a median transfusion interval duration of 86 weeks. The analysis reported phase 3 results from iMerge in the same patient population. And here are the data cut off that has been published at October 23. It gives hope that also we have another okay hope for the patient with low risk MDS. At the end, I give my thanks for Bristol Myers Squibb for presenting us, and also I give the floor for our dear colleague Dr. Badr Al Ahmar.
All right. Thank you very much, Prof. Tariq, for this is excellent presentation and an overview about the low-risk MDS and discussing novel management of low-risk MDS. Um, now the presentation is open for discussion. Please, if you have any questions, you can type them in the Q&A um, uh, Q&A icon. You can press on the Q&A icon and then you can type your questions. Meanwhile, I
I
have,
have a question. I have a question for you, Dr. Badr.
sure, go ahead.
Do you agree with me that there are misdiagnosed cases of low risk MDS?
Yeah, I mean, so in general, I mean, to be honest, we don't have an accurate epidemiological data
Yeah.
about MDS in Saudi Arabia here. Yes, it's a disease of elderly, and we see this commonly in the Western population. However, in Saudi Arabia, because our median age is much lower compared to other, let's say, Western country, for example. Um, Whether we have an underdiagnosis is not really clear until we have a robust and systemic, clear epidemiological data
Mm.
about myelodysplastic syndrome. Then we can have some conclusion. But in general, diagnosis of MDS is straightforward. I mean, anyone with
Yeah.
anemia, after like just a standard workup for anemia, rule out other cause like reversible cause of anemia.
Yes. Yeah.
If there is no evidence of cause, then you jump
Mm.
into a biopsy, which will give you the diagnosis
Yeah,
right away. So,
definitely, definitely. The
uh,
problem lies mainly in the internist. Okay, when they have the patient, okay, elderly patient with anemia, okay, they find the shortest solution, okay, by giving blood transfusion for the patient. Okay, some of these patients, when you take history from them, you might find that this condition started 2 years before, and he is a transfusion dependent. Okay, and sometimes sometimes also the acceptance of low figures hemoglobin around 9 or 10, okay? They say it's good for your age, okay? Whenever the hemoglobin is dropping to 7 or 8, give 1 or 2 unit bagged RBCs and leave him, okay? Couple of months later, he may return again and take the blood transfusion. Therefore, always highlighting for all patients, as you mentioned, Dr. Badr, if you are investigating the reversible causes for anemia and you did not find anything, okay, you have to go for bone marrow examination. It's mandatory.
Correct. Yeah, this is the point that you
Mm.
want to highlight. I totally agree with you. I mean,
Yeah.
sometimes you face like resistance from patient because this is a
Yeah.
invasive procedure. This is elderly patient. Sometimes patient or family elect not to go for this
Yeah.
procedure. Yeah, I totally agree with you. I mean, doing bone marrow biopsy is
Mm.
something really essential, and it can has an impact in terms of management because now we have a novel agent that can treat anemia instead of just
Yeah.
keeping transfusion. You can do more and more things in terms of using novel agents such as luspatercept and
Yes.
others. All right. Thank you for your question. So we'll jump into the questions from the audience. I have a question here. What about combination between luspatercept and EBO for high risk or for high transfusion dependent low risk MDS? I think you presented this, but if you
Yeah.
can again highlight this for our audience, the
Yeah,
combination between
yeah, the
luspatercept and
combination. Yes, Adis, he studied the adding luspatercept to erythropoietin stimulating agent for patient after failure to EPO. Okay, and two-thirds of the population respond again. Okay, therefore he only took the group of the patient who were EPO refractory or relapsing after EPO and adding luspatercept, they regain the RBC response and transfusion independence. Me, myself, I have 3 patients. They were on EPO. Okay. I maintained them. Also, they became transfusion dependent. I added luspatercept to them. Okay. They doing well. Therefore, I think to combine both of them, okay, they will potentiate the patient and they will give good response, okay, but it will be of high cost, okay. But definitely, there is nothing against to add EPO to luspatercept in high transfusion burden.
all right. Other question is what to expect with the luspatercept in terms of adverse events?
The adverse event that is mentioned is the bone ache, the diarrhea, okay, the dyspnea. Bone ache, it is, I think, it is the same we are facing with EPO. It has been seen in some of the patient, okay, but it's manageable, okay. Dyspnea, I saw it in one patient only, and it's of short time. Others like gastrointestinal manifestation, diarrhea, etc. It's all self-limited, okay. But generally speaking, when we are talking about luspatercept, the fear was with the more adverse event that disease progression to high risk MDS or even malignancy. Comparison to EPO, it is the same, even it is less frequent.
All right. I have another question here. Can we give luspatercept for secondary AML patients who transform from MDS who require transfusion? That means someone with MDS transform to AML, and then of course they are transfusion dependent.
Yeah.
So can we initiate luspatercept for them?
Uh,
Technically, they are secondary AML. So
Yes, secondary ML. I think we were not monitoring the low risk MDS from high risk MDS conversion or to AML conversion. Once a patient is having a secondary AML, I think the use of EPO will be more appropriate if he is transfusion dependent compared to luspatercept.
So basically, I mean, it's not approved for AML,
Yeah,
right?
yeah, no, 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 it's
Secondary
not
AML,
approved.
so
Yeah,
you cannot use it until we have
yeah,
data for that. Even for high risk MDS, it's not.
yes, not approved. Yeah.
Yeah. And okay. So the next question again, back circling back into the safety of luspatercept. I have a question here about you would like to elaborate more on in bone pain, I mean, with associated with the luspatercept. I mean, how frequent luspatercept associate like with bone pain and others?
It is variable with each patient. Okay, some of them are complaining from arthralgia. Okay, other may generalized bone ache, back ache. Okay, and of different grades, grade 1 to 2, grade 3 in limit number. But most of them are responding well to paracetamol tablets. Okay, does not necessitate analgesic. And I think with our experience with EPO, it is the same. Sometimes some patients frequently experience bone ache or bone pain with erythropoietin stimulating agent.
Okay. Prof. Tariq, I have a question. I mean, what's your experience in using luspatercept in upfront setting, like newly diagnosed, low risk MDS, transfusion dependent? Um,
I
do you,
started
I
with, yeah.
mean, do you start them luspatercept or do you start erythropoietin stimulating agent and then wait and see? And if you are always starting luspatercept, I mean, is there any population that you don't start luspatercept and do erythropoietin? So what's your experience here?
I started the luspatercept for treatment naive low risk MDS patient, especially in the elderly, in which the transfusion dependence will be annoying for them. There will be difficulty in patient transfer to the hospital and hospitalization. Okay, therefore, just to start earlier to get transfusion interval or transfusion independency will be much more appreciated. And when we comparatively look to the data presented before, when we start luspatercept frontline or second line, okay, definitively using luspatercept earlier is much more better in term of response, in term of overall survival, in term of quality of life. Therefore, since 2 years, I start to use luspatercept upfront treatment and keep erythropoietin for those patients who are either having high hemoglobin level. Okay, for example, if the hemoglobin is more than 10, okay, you can start with erythropoietin. There is no need because more than 10 gram per deciliter, even this patient can be monitored without transfusion. But patient with having hemoglobin less than 10 who will start to require transfusion, it's better to give for them. Therefore, you can put a cut level is hemoglobin around 10 gram per deciliter. If the patient is having more than that, you can start with erythropoietin or even follow up of the patient. If the patient is having less than that, for fear of becoming transfusion dependent, you can start it upfront. Dr. Badri, you are mute.
Yeah, sorry. So from
Yeah,
the command study, you already highlighted that the question, just if you can highlight it again, the
mm,
predictors of response for the upfront, uh, you already mentioned,
yeah.
uh, you already
Uh,
mentioned.
the overall survival, okay, is higher. The transfusion independence in terms of months per transfusion independence is also higher, and the response rate is higher when we start luspatercept upfront compared to second line luspatercept after erythropoietin. And
And
when we
that's
look,
based on the simulation model. I mean, we
yeah,
don't have
simulation method.
such data in
Yeah,
the randomized
yeah.
study. It did not
But
show
yeah,
difference
but
in the.
when we look for the command trial, I think it is amazing because it compared both arms. Okay, it is comparing either frontline versus luspatercept frontline, and this comparison in terms of transfusion independency, whether the patient is have high transfusion burden or low transfusion burden, whether the patient is having low or high EPO level, whether the patient is with ringed sideroblast or not, or patient even with SF3B1 mutation not, all patient subgroup they were better in the luspatercept arm compared to the EPO. Only those with absence of ringed sideroblast, which is not an indication for luspatercept, this EPO behaves better.
Oh. I have a question from the audience about do you have any experience using luspatercept in uh, beta thalassemia?
Yeah.
So can you
We
share
have
your
in beta
experience with
thalassemia, my experience in non-transfusion dependent and transfusion dependent. And non-transfusion dependent, we start to use it in patient with having low hemoglobin, less than 9 gram per deciliter. We had patient around 8 or more, or even less than that. We achieved patient hemoglobin for 11 gram or more and non-transfusion dependent. At that time, we start to propagate the frequency until we achieved Q6 weeks. We can eliminate it. And the transfusion dependency patient, we achieved transfusion independency. For example, patient who were requiring 2 units every month, we have achieved a transfusion interval of 3 months interval by keeping the hemoglobin around 9 gram per deciliter without transfusion for 3 months. This is the best scenario we have achieved till now in the transfusion dependent thalassemia. And I think in transfusion dependent thalassemia, if we can reduce the transfusion burden and subsequently the need for chelation will be less more and more, it leading to improvement quality of life.
What's your experience in terms of iron chelation in MDS in general?
Mm, I did not use it before, except in very, very limited a number of cases. If they have a very high serum ferritin level and they have a high other comorbidity affecting the liver, if the patient is Hep B or Hep C before, or having fatty liver, okay, in this concern, I was afraid about having deterioration of the liver parenchyma. But if not, I can consider the serum ferritin as a marker, okay, for patient improvement or not. If it is responding to the erythropoietin or luspatercept by reducing serum ferritin, means there is a response to treatment. But generally, as in leukemia, the patient is having a very high serum ferritin. We are not looking at that time for the iron chelation.
Okay. I think we have no more questions.
What about this question for you, Dr. Badr?
Yes, go
Iron
ahead.
chelation in MDS.
Yeah, I mean, iron chelation in MDS, I mean, there is really limited data about the use of
Yeah,
iron chelation in MDS. Of course, the question is usually for those who are transfusion for a long time, and some subset of patient might need some iron chelation. There has been a randomized study at a slower scale using iron chelation. And the study, of course, did not complete accrual because of the problem with the recruiting patient into that study. And it did show improvement in the, they call it event-free survival. In terms of event-free, that means any cardiovascular event or hepatic event or whatever related to the, but there was some improvement. But again, I mean, the data are limited and not really conclusive. But still, I mean, um, some people, they are really heavily transfusion dependent, and
yeah,
they might start to show some iron toxicity. So if you do like liver MRI, you will see that T2 star is somewhat elevated. So they might benefit from iron chelation. But
iron
again, I
chelation.
mean, those patients are elderly. They have huge burden in terms of medication and others. And the last thing that they want to do is to take oral chelating agents. So it's really challenging even to deliver the this kind of treatment. Yeah.
Yeah,
So it's not really routinely used, but we always keep it in our
yeah,
mind.
and this
If
exactly.
patient needed, then we have
Yes,
to think
yeah.
about it. Uh, there's another question about myelofibrosis. So that there's an interest in luspatercept
Mm.
tonight. So about luspatercept and myelofibrosis, do you have any thing to mention about it?
I think there is an ongoing trial about the use of luspatercept in myelofibrosis, okay, and the data presented in term analysis is promising, okay, for the patient, but not all cases of myelofibrosis, mainly in the primary myelofibrosis, not secondary.
All right. So I think we are coming to the end of our session tonight. It is really my pleasure to
Yeah,
be with you tonight, Prof. Tariq, and with the
yeah, that
audience
was my thing.
that is who are interested in the SSBMT webinar. It has been a great pleasure to be with you, everyone, and many thanks to our sponsor, Bristol
Many
Myers
thanks.
Squibb tonight, and wish you all the best. Thank you very much, everyone. Thank you.